sides of the charts and everything. Oh, how are you?
We are now live.
I just read it's very, yeah. Been a lot of people.
Well, good that I like the program, right?
That was quick. Write it down.
Cases is like an observer, not a administrator. Anyone that logs in, they don't take over.
Oh, really?
And that's what was happening with it. Genesis was technically not listed as muted, so then he took over the broadcast.
So there's muted and then automatic. So we're gonna have to ask Francis to add that to the email and it's bold. Do not, please keep my comments.
Well, fellas are good at this too, and
Yeah. Yeah. But it shouldn't automatically hijack the system. If you have more questions, very happy to answer that and everything about my Oh wow, very wow. You're very hard to run.
Hey, Harry, what you want?
Yes, yes. Okay, stop making her nervous.
Well, I think it's just because nothing like.
No. They heard about penicillin
It's always good. That's what you have to remember. It's always good. That's my
I always say that. I like, no, that's not a thing. I like it. No, you didn't. No, you didn't.
yeah, that's right. Yeah, I'll give you a heads up for that. That's great. Yeah, so a little.
I know. I think people tell me when they use dial in, they're like, I'm gonna try to do 7 a.m.
I know. I think of the time change this week. I'm like, I'm trying to get.
Yeah, no, that's literally why I actually sound like a normal person.
Nice to see you.
Normally,
Give it about 10 days.
Yeah, I know.
I
Yeah.
know. It's like, oh,
I know. I mean, I still stay up.
Let's go ahead and sit down and get started. Drew reminds me we should start on time or early because we have 2 speakers this morning, and we got a fair amount of material to cover. The first speaker is Anna Wald, and I asked Anna to speak because she is the new head of AID here at the University of Washington, Allergy, Infectious Disease, and she's not an allergist, she's an infectious disease specialist, so I thought it's important for our half, or maybe 1/16, there are a lot of ID people and not as many allergy people. For the rest of us, I have met her on a number of occasions to know who the chief of the division here at the university is. So she's going to do the first half of the presentation. At first I asked her just to give an overview of the division. She thought that would be okay, but also to tell us how she got her career and what she does in infectious disease. And we have a visitor from Vanderbilt today who's going to be a second speaker, who's going to talk about drug allergy evaluation and testing and work that he's done during his fellowship. So let's go ahead on.
Good morning, everybody. Thank you, Len, for letting me come here and talk to you. This is an ungodly hour to have talks at, but ID people don't do this. Okay, so here are my disclosures. I do work with some drug companies. Most of my support, however, comes from NIH. So I'll talk a little bit today about both my academic journey and also my vision for the division, in particular how allergy fits into it. I started medical school in 1981, which was the same year that this article came out. This was in an issue of New England Journal, that had 3 different articles, first articles on this new syndrome that we now call AIDS. The articles that are well known from that journal is the one on KS, the one on PCP, but this was actually yet another article in the same issue of the journal that talked about severe chronic herpes simplex lesions. And these are some of the examples of the herpes lesions that clinically would have been seen. But I'm showing you this just because I was trained sort of throughout. I went to medical school in New York City, starting in '81. So I was there during the early days of the HIV epidemic. Then as the epidemic moved to injection drug users, I did residency at Boston City Hospital. So we saw a lot of HIV there. So I had this sort of natural attraction to ID because HIV is really what I knew. So I was a very good HIV doctor before I ever did an ID fellowship. One of the earliest studies, and still I think the study that has been cited most times out of my work, is this study where I looked at the risk that HSV-2 infection confers for HIV acquisition. So we know that there are some behavioral risks for HIV acquisition, but there are also some biological risks. And there have been many studies now. At the time that I did this, I think there were about 20, this is a subset of them, that showed that having HSV-2 infection is a risk factor for HIV. Now, why would that be? It turns out that it's not just the genital ulcer that's the risk factor, it's actually having HSV-2 infection. So we spent several years trying to tease out why that was. But we thought that maybe we can leverage that observation into an opportunity to prevent HIV acquisition. So this was a very large study that we did that was actually done both in 3 places in Africa among heterosexual women and in US as well as Peru among men who have sex with men. So we took those 2 groups of people that were at high risk for HIV acquisition and we randomized them to receive acyclovir 400 milligrams BID, which is the standard suppressive therapy, or matching placebo. And when people had outbreaks, most people, they were able to receive episodic therapy for genital herpes. And primary endpoint was HIV infection. And here you can see the results. The study was successful in terms of the way it was done. We enrolled over 3,000 participants. We had excellent adherence with therapy, and we could demonstrate it because those that received the acyclovir did not have very many recurrences. We had very good follow-up at 18 months. 85 people were still enrolled, and there was no difference in terms of the numbers of people that acquired HIV. So this intervention clearly did not work. So then we started asking the question why. And this has led to several papers, including this paper by Jaju, who's laboratory medicine here and a close collaborator. And she showed that when we do biopsies of people that have HSV-2 infection, that they have an increased number of CD4 cells, not only in their lesions, but also in the genital area in general. So you can see here that when we look at CD4 cells, they're increased in the tissue in comparison to blood, not surprisingly. They're higher in the lesions versus control sites that are not affected by HSV-2. But when we treat them with a suppressive therapy, the number of CD4 cells does not change, which has led us to conclude that both the reason HSV-2 is a risk factor for HIV acquisition and why the intervention did not work is because HSV-2 changes the immunological milieu of the genital tract as to increase the number of entry cells for HIV. And that cannot be modified by acyclovir. So this was an immunological rather than sort of a genital ulcer explanation for why HSV-2 increases the risk of HIV. There was also a lot of observational data that having HSV2 increases the risk of transmission of HIV to sexual partners. So then we did this study, Partners in Prevention, where we enrolled over 3,000 HIV discordant couples. So these were heterosexual couples in Africa. One had HIV and the other did not. And everybody who had HIV also had HSV2 infection. At the time we were doing the study, the cutoff for antiretroviral therapy was 250. So we enrolled people only with higher CD4 counts of 250, so they were not on antiretrovirals. And we randomized them to acyclovir versus placebo, and we followed the couples for a couple years. And the primary endpoint was HIV infection in a HIV-negative partner, and also HIV disease progression. And here you can see another completely negative study. So these were two very large randomized clinical trials that were completely negative. Again, we had excellent adherence to therapy with reduction of genital ulcer disease, excellent follow-up, and no difference in the risk of transmission. And you can see here that we actually documented that these transmissions were linked. So the viruses were sequenced, and it was demonstrated that it's the same virus that was transmitted from the source partner. So both trials had null results. We published out of this more than 60 papers, so certainly academically it was fruitful. There was a lot of insights into pathogenesis of HIV that were started, and it clearly demonstrated the need for more potent therapies for HSV, right? Therapies that would not only abrogate genital ulcer disease, but would actually affect whether or not the immunology that is conferred by HSV2 changes. And there were lots of questions that sort of came out of these two negative studies. Since antiretroviral therapy has now, we do test and treat pretty universally across the globe, I think this issue of genital herpes has become less pertinent, although I have to say that even in the current era, HSV2 is still a strong risk factor for HIV acquisition. But this is just to show you, this is from a study by Lynette Massessa, who's actually a resident here in internal medicine right now. I'm not an author on this study, but she worked with the UW Mombasa collaboration, and she showed that when you're looking at which genital tract infections make a contribution to HIV acquisition in high-risk women, HSV2 predominates throughout pretty much all of the years. So it is an incredibly important infection in terms of the HIV epidemic in Africa, and we don't yet have a good way of mitigating it. So that was one part of what I did. The other part is that I was always an active clinician, and patients always wanted to know, why is my herpes so bad, and how can I prevent transmission to sex partners? And we tried to learn about it and then apply these natural history lessons to drug development and also vaccine development. Now we have developed this approach to studying the severity of disease where we test patients with the HSV Western blot to see whether they have antibodies to one or two. And then we provide them with this kit, and they collect their own swabs on a daily basis. Patients are very adherent to this because they really want to know whether they are shedding. So when you have HSV2, you not only have genital ulcers, but in between, HSV is present in the genital tract, and most transmissions occur during those times when there is no genital ulcer. Initially, we started having patients collect the swabs once daily. Initially, we used culture. Then when PCR became available, we switched to PCR. And these are some of the things that we observed. We also, about 10 years ago, started asking patients to obtain several swabs a day. So this is a study, just to show you an example, of 25 participants, where they collected genital swabs about every 6 hours. We did let them sleep 8 hours at night. And I think it's pretty amazing that on 74% of the days, they actually collected all 4 swabs. The HSV DNA was detected on 20% of the days, which is about what you would expect in a cohort of people with active genital herpes. And you can see some of the patterns here. And you can see that some people had these shedding episodes that lasted several days. Okay, these were more likely to be associated with lesions, although this person did not have any lesions during this particular month. And you can see that they also have a sort of characteristic distribution where the first viral load, appears to be the highest, and subsequently, as the immune system kicks in, it goes down. But you can also see that there are these short episodes. So this is an episode that's present only during one of the 6-hour intervals, right? So there's a negative, a positive, and then a negative. And you can see that obviously the immune system kicks in very rapidly to contain this replication. And about half of the episodes that we observed lasted less than 18 hours. So in fact, this infection, historically we think of it as people having recurrences 4 times a year. But instead, it turns out that this is an incredibly dynamic process where the virus tries to reactivate all the time, and most of the time, immune system successfully contains it.
How do you know the immune system's containing it? We just don't know they're shedding.
Because their swabs are negative. So here, where there's nothing, it means that the swab was negative. There's no virus present.
I know, but how do you know the mechanism that's containing it?
Because otherwise viruses and bacteria replicate when they're unchecked. Right, so the absence means that these persons were not treated.
Yeah, I'm just asking how you know what that something is.
Well, I think that's a fair question. We do know that there's a lot of immune response in the tissue. Now, can I demonstrate that this particular episode, was sort of not stochastically burned out versus immunologically? I can't. But we do have a lot of data that I can't show today on immunology in the genital tract because we do a lot of biopsies. So we're pretty sure that it's the immune system. So then we ask the question, can we use viral shedding as a surrogate endpoint in the development of new drugs and vaccines? And this is really important because especially for vaccine, we don't have an immune correlate of protection. So we don't know what it is we should be measuring in the blood in order to say that somebody will have mild disease or will be protected from acquisition. These are the definitions that are FDA sort of promoted of a surrogate endpoint. And I don't know how much you guys think about endpoints. I think some of you, I know Bill, some of you, your work has also been about endpoints. So I think this is probably somewhat relevant. FDA is very concerned about approving any drugs based on endpoint data. And this huge concern comes from this CAST study that was a study of these new drugs, enconide and flecainide, that seemed miraculous when they first came out because they stopped people from having arrhythmias. And they worked very well for people who stopped to having arrhythmias. And therefore, there was a large study done to ask the question whether they will prevent death. And it turned out that yes, they stopped arrhythmias, but they killed people. So this was not, clearly stopping arrhythmias was not a validated endpoint for these drugs. And as a result, FDA has become much more stringent in order to be able to approve a drug based on surrogate marker activity. So we wanted to go through this here and validate viral shedding as a surrogate marker for development of antiviral interventions. And I think it's a little bit different in infectious diseases because pathogen is required to cause infection-specific syndromes. So you can't really have genital herpes unless you have HSV infection. Well, that seems obvious to a lot of ID people. That's not the way FDA regards it. They regard it just if it was just another surrogate endpoint. So what we wanted to show is that if you take intervention, such as a drug, and it has an effect on viral shedding, that it will also have an effect on clinical disease, and that this effect on clinical disease will be mediated via viral shedding. So first we needed to show the relationship between viral shedding and herpes recurrences. And then we did in these natural history studies that I described to you. So for example, if we take somebody who has a genital ulcer and we sample them, not 4 times a day, but this is actually every 5 minutes, you can see that our detection is pretty consistent of the virus, right? The other thing, some people think that you can just take a shower and then your herpes will somehow be washed away. And clearly that is not true. The virus replenishes itself very rapidly after you try to wash it off or swab it away. We have also shown that there's a very good correlation between viral shedding and lesions. So if people who shed a lot have a lot more genital lesions, which is not really surprising. And we showed that within person, there's strong correlation between shedding at one session versus another. So people who have a certain severity of disease seem to stay with that severity of disease over several years. It doesn't really change that dramatically. So we showed that HSV shedding frequency can establish a phenotype for the severity of virological infection. It's consistent over time, statistically, because there's a lot more shedding than lesions. It's more powerful, correlates with lesion rate, which is the FDA endpoint for clinical disease. So we showed
how far
that.
apart, the 2 measurements you had there within person, how far apart are those? Roughly? Like,
There were, I think on the average, about 2 years. So we showed this piece of the equation. And the next thing, we looked at this drug study that I did with Acurus. This is a helicase primase inhibitor, so a different mechanism of action than the currently available herpes drugs, where we did a phase 2 proof of concept study to address whether this drug will stop viral shedding. The study design was a dose-ranging study. We had 5 groups, you can see over here, and people were randomized to receive one of those 5, and they collected daily swabs for HSV and maintained a diary of genital lesions. And the results are shown here. So you can see a dot means a person's shedding rate. Shedding rates are over here. So this is the proportion of days on which shedding was detected in the study. And this is each dose, including placebo. So you can see that shedding during this 30 days that people collected the swabs is variable, and you would expect it to be variable. That's the natural history of the disease. But on the average, people in the placebo group had substantially higher shedding rates than people who received the appropriate dose of the drug. So you can see that the drug was incredibly effective in containing viral shedding. So we showed this, that if you use a good drug, you can show that you have a good effect on viral shedding. And when we looked at the relative risk of lesions, when you were giving drug, you can see that the relative risk was decreased by about 90%. So clearly, the drug had an effect both on viral shedding as well as lesions. And if you then put the viral shedding back into the equation to ask the question, if you control for viral shedding, is there an effect on lesions? You can see that the significance of the finding goes away, meaning that the bulk of the mechanism in how it controls lesions is mediated via viral shedding. So we subsequently went on and showed, also using viral shedding, that pritelivir is more potent than valacyclovir in terms of reducing both viral shedding and lesions as well. Unfortunately, the drug right now is on clinical hold because of some findings in monkeys, but I'm hoping that eventually we'll get to work more either with this compound or with another drug that has this mechanism of action. And let me just also say that we have also been working for many years now on a therapeutic vaccine. So that would be a vaccine that's given to people that are already infected to control their disease better. And every company thus far has wanted to use viral shedding as the endpoint in their proof of concept study. So that's been kind of fun because they come to us and say, help us design these studies, and we're about to start yet another one. One of them actually showed about 50% efficacy. And now we have a new one that we'll see how well it works. So I've also done a lot of mentoring. I've had a K24 for 2 cycles, and I work both here on manuscript writing workshops as well as internationally now for more than a decade. It's been a really fun part of my career. So there are a lot of people that I have worked with in our division and outside. So now I wanted to spend a few minutes just talking about our division. I think we're one of the largest divisions. The exact number is very difficult to count because everybody counts their faculty a little bit differently in terms of the adjuncts and affiliates. We have a very large grant portfolios, one of the second biggest after oncology right now in Department of Medicine. As you all know, we have 2 specialties within our division, which is also pretty unusual. We have 3 fellowships. At any one time, we have about 37 fellows. In infectious diseases, we have 3 training grants. And given that, we have relatively low number of full-time clinical FTE. So even though we staff all of the hospitals, given the number of faculty that we have, most faculty don't do don't do a lot of clinical time, just because there's not that much to go around at this point. This just shows that we have a lot of research that is going on. And also, our division has a lot of people that have direct administrative responsibilities in the hospital. So infection control, antimicrobial stewardship, associate medical directors, and then of course Tim Dallett, who heads UW Medicine, is also in our division, as is Santiago Neme, who's the medical director of Northwest Hospital.
What's the big black part of that?
That's research funding. Most of it is NIH. So you can also see that the indirects that we get back from the institution are pathetic. Okay, I just want to highlight a few of the areas that we are working in right now and that I really hope to expand. My goals for the division was to continue to increase our space, to really grow the allergy section. I'm also very committed to tele-ID. And then there's this LEAF program that I'll just mention briefly because especially some of the fellows may find it useful. I think it's important in general to make succession plans in our programs. It's very also important to increase diversity, and we have a very active diversity committee in the division. And then the most brilliant thing I did was to ask Bob Harrington to become the associate head for clinical services, but unfortunately he was then tapped to become the vice chair of medicine at Harborview. So he's still helping me, but obviously he has a very small bandwidth at this point. You know that this is a fairly small allergy program. I think we have continued a clinical need that is unfulfilled. There is also a huge need in pediatrics, and I have, you guys have been very encouraging of me to pursue that, and I am meeting with the chair of pediatrics later this month. I would like to hire at least one more physician scientist. I'm hoping to actually hire somebody in food allergy because I think that's a growing and very interesting area. We are hoping to get approval to have a full-time clinician at Harborview Medical Center. And then we've been throwing around various ideas on how to more efficiently conduct inpatient allergy testing, sinus disease clinic. I know, Drew, that you've been very committed to that, and to have a transition clinic for immunodeficiency patients that transition from Children's Hospital. And we were able to convince UW-MC to provide some salary support to Lahari for antimicrobial stewardship, because I think that's a really important component of how to use antibiotics wisely. So there are several things that we are planning on doing. Tele-ID, as well as maybe tele-allergy, is obviously a growing area, especially infectious diseases, where I'm running out of clinical opportunities for my clinicians. It's going to be a while before I think we run out of allergy clinical opportunities. But there are a lot of critical access hospitals in the WAMI region. that don't have an ID doctor, and yet there's a huge need. So we've been working together with John Scott, who is the head of digital health at UW Medicine, to see how to implement these contracts and how to do it. We also have a very successful antimicrobial program, in which this is a weekly program that's by subscription in small hospitals. We have now 50 hospitals that subscribe to it, that they get support on how to conduct antimicrobial stewardship activities at their hospital. And actually, Lahari, you should go and you should talk to them to see whether you can help out with some of the sessions. And this has been very, very successful. This is what I mentioned before. It's called LEAF, which is a tool that was developed by Bob Harrington and now is sort of run by Nina Kim, which is a self-service tool that allows anybody with minimal training to query medical records, to get an idea of how many patients, for example, with a certain disease we have. So for example, last night at dinner, we were discussing how many patients with DRESS have we seen with our system. So this is something that somebody could just go and look. If you want to go deeper, if you want to actually look at the charts, then we actually have an umbrella IRB that allows us to do all of those projects under a single IRB. So you don't need to go and put in an application for your own project each time. And I think that has facilitated these collaborations.
So how does that work? Does anybody within the department or
division right now? Yeah. So talk to me, we just have a form that you used to sign. Now actually you don't even have to sign. I think we just put you on the list of people that can do that. So we have a lot of, is there another question? No. These are some of the projects that have been generated using LEAF, and Hannah Imlay, who was a ID fellow who actually just left. She got a job in Utah, published a nice paper looking at beta-lactam allergy testing pre-transplant. So clearly there is a platform that can be utilized for many different types of projects. I'm going to stop here. I want to make sure that I give enough time to our other speaker and to see if you have any questions. Thank you. Yeah?
I was just curious on the vaccine. Is that for HSV 1, 2, or both?
Well, so that's a great question. The vaccines that so far have been done, the therapeutic vaccines, have been for HSV 2. We think that an HSV 2 vaccine will probably also have an effect on HSV 1. So if you have HSV 1 infection, you can still acquire HSV 2. But if you have HSV 2 infection, you almost never acquire HSV 1. So immunity to HSV 2 also prevents HSV 1 acquisition. So we hope that the vaccine will have a similar effect. Yeah?
Through all your work, have you found any differences between the severely affected HSV2s? Nothing.
No, I feel like 20 years I've spent writing grants about this.
Yeah.
And, I worked with some pretty sophisticated immunologists, and we have not been able to pinpoint it. It does seem to me that the host is more important than the virus, because when you're looking at couples, the severity that transmit, severity in one does not correlate with severity in the other. And we know they transmit the same virus. The virus doesn't mutate very much. So you would think that it's mostly the host. Although we also did a twin study in which we showed that there is some effect of the virus as well.
Have you noticed any difference in the people that are serologically positive but never express disease? Have you looked at that cohort of patients?
We have. That was actually my fellowship project. They shed, but they have, and most of them are actually symptomatic, but they have lesions that are mild and subtle. So many of them have clinical disease that they don't recognize as being HSV related. So in this part of the country, they have, they come in and they have, that's just my rub from my bike seat. Or they have a spider bite, recurrent spider bite. So people attribute lesions in the genital area to other things than herpes pretty easily, or women have recurrent yeast infections. But it turns out that a lot of it actually is, we've documented that it's virologically HSV2 infection. And most transmissions actually occur from people who don't know that they have the disease, about 80%. So those people are the most common source.
And changes in the microbiome, are there some alterations that could be, are you optimistic in the future that could be a therapeutic area?
So Christine Johnston just finished a large study looking at microbiome and BV, bacterial vaginosis, and HSV2, and there is really not a very strong association. So unclear that microbiome will modulate that. So, all right, thank you for letting me share some of my work, and I'm here if you guys have questions.
So David Coleman's nice enough to travel up here from Vanderbilt and give us, I think, work you've done in your fellowship on drug allergy evaluation and testing.
Thank you.
Thanks very much for that introduction, and thank you very much for allowing me the time to speak today. My clinical interest in allergy is drug allergy, and so I was hoping to present to you some of the clinical work we do at Vanderbilt to help patients with drug allergies. And I have nothing to disclose. So by the end of this 20-minute talk, I would like to talk to you emerging testing strategies for evaluation of penicillin allergy, discuss our intraoperative anaphylaxis, and define our testing strategy for such, and then also to define our sulfa testing strategy. So first, a primer on penicillin allergy. No talk on drug allergy is complete without this introductory slide, that if you take all patients, it turns out about 10 to 15% of them currently have a penicillin allergy diagnosis. But then if you provide the gold standard of testing, which is at this point skin testing followed by oral provocation, only about 5 to 10% of those currently are mounting reactivity to penicillin. And so studies have shown that 75% of folks with a penicillin allergy have acquired their penicillin allergy by the age of 3, generally due to maculopapular exanthems. And as an internist now taking care of children, I learned that children rash. And so that is something I've learned as an internist now taking care of kids. So this was a really interesting landmark study in 1993. Basically, an STD clinic tested 776 patients with a history of penicillin allergy. And they found that regardless of the history, 7.1% of them reacted. So that's sort of, and this is just skin testing. This was not followed by the gold standard of oral provocation. The thing that I found most interesting about this paper and why it was more landmarked was symptoms that any allergist would say it was anaphylaxis and thus a very serious reaction that potentially would necessitate a lifelong avoidance of penicillin. Only 17% of those patients were reactive to penicillin. And so this was suggestive that perhaps patients lose their penicillin allergy over time. And this data is recapitulated by our data. This is about 400 patients that we've seen in our clinic with penicillin allergy. On the y-axis is the probability of a positive penicillin skin testing. And on the x-axis is time between the penicillin reaction and testing. And as you see, as time increases, the probability of testing positive via skin testing to penicillin drops dramatically. And so the first thing I'm sorry.
Sample size roughly on that?
Yeah, it's about 450 patients. So the first step in assessment of a penicillin allergy is characterization of risk. And we do this all the time, but algorithms are helpful in order to potentially make this more standardized. So this is what we publish as our risk assessment algorithm. So imagine it like a traffic light, red, orange, as opposed to yellow and green. So reactions that we would not challenge are those that sound consistent with scars or severe cutaneous adverse reactions that are T-cell mediated. So SJS, TEN, DRESS, AGEP, or any symptoms involving the mouth or mucosal surfaces. There are some folks who are currently challenging serum sickness, but that is not currently part of our algorithm. The orange or intermediate risk involves patients within the past 5 years who have had symptoms consistent with anaphylaxis. So 2 or more systems involved within the past 5 years which sound IgE mediated. And those which are green lighted or low risk are those that have a low risk for history. Greater than 5 years ago, urticaria only greater than 5 years ago, a self-limited cutaneous rash, or those that are incompatible with allergy, such as gastrointestinal symptoms, a family history, or avoidance of fear from allergy only. Which happens a lot, which happens more than you may think. Also, I don't remember the reaction is also considered a low-risk history. And so our penicillin testing strategy is more than just pre-pen at this time. So this is what we create so we buy pre-pen, but the rest of these compounds are compounded by our pharmacy. So we use penicillin G at 2 different concentrations, a mixture of minor determinant factor at 1 to 100 dilution, and ampicillin at 25 mg per mil for all patients who come to our clinic with a penicillin allergy.
How do you make the minor determinant?
So it's created by the pharmacy, and they compound it, they buy it, and they make it in their pharmacy. Yeah, I wish I knew exactly the details on that, but it is created by our pharmacy. So in those who are in the orange category, we start with prick testing, but those who are in the green category, we start at intradermal testing. And so this is a typical picture where this patient reacted to histamine, not to saline, and not to the penicillin G, pre-pen, minor determinant, or ampicillin. And so that's negative. And our drug provocation for those who are in the green zone, which is probably about 80 to 85% of patients, is a single dose of 250 milligrams of amoxicillin followed by 1.5 hours of observation. And before the patient leaves in EPIC, we fill out this table as our assessment and plan, which is then put into the patient instructions, making it very clear that our recommendations for the patient that it would be safe to administer penicillins. In our addendum to the providers, we do caveat that there's a 3 to 5% chance of a delayed maculopapular exanthem, which we state is unlikely to be, a contraindication in the future administration.
Do you need to do the intradermal testing if they're low risk, or can you just go straight to the oral amoxicillin?
So that is a topic of great study, and there are many studies that have shown that you can go straight to oral challenge in patients who are low risk. We're actually doing one in our ICU right now. Our patients, we have a nurse provider clinic that does patients with just penicillin that are all low risk. And our patients are in the MD clinic are more multiply labeled, which we've showed last year. One of our fellows showed that those patients have a higher incidence of anxiety, mistrust of drug allergy assessment. And our stance now is that skin testing reduces anxiety for a lot of these patients. And so that's why our schema does include skin testing at this time. And we give these recommendations to the patient, the PCP, the referring provider, and it's also faxed to the patient's pharmacy to try to do our best to capture the appropriate providers that what had happened in our clinic. So with
excuse me, I think your question goes back to a fundamental difference between allergy and ID on how to. So ID has always felt that the history wasn't anaphylaxis, just go ahead and give the drug. We've always said we ought to test first. It's kind of been that way.
But it's also how to test, right?
Yeah.
Right. Can you just give the oral dose?
Kind of a related question is how often are patients only ID positive?
Never, almost never. Yeah.
So that
I'll show you one in a minute.
Yeah.
So one question I've always had, way back to the beginning here, you assumed that everybody initially did have penicillin allergy and then lost it from that curve you showed us. I'm assuming most of those people never had penicillin allergy and the history was wrong from the get-go.
That's true. That is an important part. That is an important caveat.
Do we
to
actually know the difference? Do we know how many people truly had penicillin allergy in childhood and lost it over time versus people who just mislabeled from childhood?
Yeah, I'm not sure that study has been done yet. I'm not.
Tim Sullivan, a long time ago, had like a JCI New England Journal paper. He skin tested kids and he followed them over like a 10, 20-year period. He started UT Southwestern, followed up at Emory, and I thought he was sort of the one who showed the loss over time. Was well documented.
But he also
probably
had
like
some
in
other
the
things
80s,
wrong.
90s.
He also said that like 50% of cephalosporin allergy was cross-reacted with penicillin, as I remember.
Right, but his first papers were on documentation of loss of penicillin sensitivity, where people that were positive that they subsequently tested 5-10 years and came out with a general kind of parameter we all thought of, that it was like every decade you have 50% loss of your IG sensitivity.
But when he tested young kids, when their history was first said to be positive, they gave a history of a rash with a penicillin. If you test them at that age, what percentage of them were actually positive versus mislabeled in the first place?
That makes
So-
about 10%.
There was a recent study that was generated, I can't remember which institution, that in pediatric patients between the age of 4 and 8, I believe, had 1 to 2 minor symptoms immediately following penicillin ingestion. And if they were not anaphylactic, they went ahead and just challenged 100 of them. They originally had 300 patients in their cohort and challenged 100, and all 100 passed. So.
That was David Viles at
Yes.
Wisconsin.
Right.
And that would say 100% of them had a mislabel.
Exactly.
They weren't allergic to penicillin.
No, it was probably part of the viral illness.
Can I just say one caveat about you guys, the way you do your challenges?
Yes, ma'am.
Technically, I don't know what you're billing it, but if you don't give a sequential dose, you can't bill it as an oral challenge. And then you don't get paid for your time. So I would just say if you talk to Teresa Thompson, she'll say give 1/10 of the dose and then 9/10 of the dose. It has to be sequential doses. You cannot bill an oral challenge if you just do a single dose. So you should double check that.
I think that's an issue for private practice, not for
If
academics.
anywhere, you can't bill a challenge dose if you're not giving more than 1 dose.
We switched to a graded challenge. You have to have 2 doses.
Because otherwise you're not billing it correctly. And you're not getting paid for your time.
Well, why are the 2 doses of penicillin? Like, why?
At 2 different concentrations. So there are some. So in some patients, this can cause So oftentimes we do 2 concentrations of skin testing to potentially capture non-IgE-mediated mast cell activation. Penicillin G is not one that's generally associated with that, but that was the initial decision why that was made. And so we do plenty of medications such as vancomycin, Zosyn, ondansetron, where at the high concentration they're reactive, but the low concentration they're non-reactive, suggesting of non-IgE-mediated mast cell activation.
Specifically for PenG, there was a study a few years ago when they compared the concentration of 10,000 versus 6,000. People with 10,000 had more false positives, and that's the reason. And,
It's irritating, it stings.
and when I was in Einstein, we used to do 3 concentrations, 100,000 and 10,000.
But you have the mind to determine it, so it's just weird why you would proceed with that. Like, because then you challenge after that. So you can be confident. And do you do 1 set or 2 sets when you do the IDs? Do you do 1 set of IDs or do you do 2 sets of IDs?
1 set.
1 set? Okay.
Yeah. Well, I think part of drug allergy testing and evaluation is understanding your pre-test probability. And so in patients who have a low pre-test probability and react in the way you're expecting them to, I don't know if there's a utility in doing a second set.
Just on the guidelines.
Do you ever test for clavulanic acid?
We rarely do oral challenges to clavulanic acid. We don't do skin testing for clavulanic acid because we don't do intradermal tests to things that are non-sterile.
Well, you can use Timentin, and you can use it that way, but I have found a couple people that give their history of augmentin reaction, penicillin testing negative, and then they're positive to clavulanic acid.
Yeah, I think that's I think there is a role for testing to clavulanic acid. I think those patients are rarer than ones that are pure, to the amoxicillin component of that. But and that's why we just go to oral challenge for patients like that. So if I may continue.
I'd be very interested in where you get your minor determinant.
I'd be happy to report it.
I mean, that's been a problem forever, to have a source of minor determinant.
Well, I think so Roland Solansky recently put out a paper in JACI in Practice, and they're creating a new FDA-approved expanded testing schema for penicillin allergy, which includes sterilized amoxicillin, minor determinant factor, which includes mixtures of penicillin G and pre-pen, of course. And so hopefully in the future it will be a lot more easily obtainable. I'd like to chat about perioperative anaphylaxis. So this gentleman is 61, and he came with the chief complaint of, what did I have an allergic reaction in the operating room to? I'd really like to have this surgery. So he's otherwise healthy apart from prostate cancer, for which prostatectomy was indicated, and he is on no medications and has no prior medication allergies. Prior to the surgery, which was 3 weeks prior to our consultation, receives, and I just have a slew of these. I don't know what order they're in. I'm not sure, I'm not sure what the last one was, but these were all the medications that this patient was provided just prior to his prostatectomy. And the prostatectomy didn't even start because he became hypoxic to the mid-80s. He was hypotensive. He became relatively hypotensive, and he had a classic urticarial rash. They had to give him 2 doses of epi before he turned around. Then they gave him H1 and H2 blockade and steroids, and he did well after that, but unfortunately now does not have a prostatectomy. So intraoperative anaphylaxis is thought to occur between 1 to 10,000 and 1 to 20,000 of cases of intraoperative surgeries. And it's really tricky to diagnose because sometimes hypotension can be misattributed as a side effect of induction agents. Skin is often covered by draping, and airway is often protected. It's estimated that about 60% of reactions are IgE mediated, and the remainder are due to non-IgE mediated mast cell activation. And so we've all learned that drugs can bind, that if one is sensitized, drugs may bind to the Fc-epsilon-R1 receptor complex and induce degranulation. However, there are some drugs completely distinct from the immune system, such as antibodies or T cells, where the pharmacologic properties of these medications can bind to off-site receptors, such as MRGPRX2, and cause a similarly looking degranulation event. And so the prototypical example for this is vancomycin. And what can we learn from the perhaps non-PC term red man syndrome is that it's less likely to cause anaphylaxis, though still can be very serious. It's dose and rate dependent, and it's mitigated by antihistamine pretreatment. And so some of the drugs that are implicated in non-IgE mediated mast cell activation sound very similar to many of the drugs that my patient received prior to induction. So neuromuscular blocking agents, opiates, radiocontrast dye, fluoroquinolones, it's basically everything he received. This was a paper in Scientific Reports a couple years ago documenting the role of MRGPRX2 in non-IgE mediated mast cell activation. In a prior figure in this article, they showed that vancomycin in a dose-dependent manner induced mast cell degranulation measured via beta-hexosaminidase release, which is a common laboratory schema for testing mast cell degranulation. They created small hairpin RNAs, which act as sort of a silencer for MRGPRX2 in a non-target, and they showed that this completely reduced the ability of vancomycin to induce mast cell degranulation when MRGPRX2 is targeted. And there were similar findings in this paper for morphine and cisatracurium. And so, as far as IgE-mediated mast cell activation, I'm sure this is perhaps review, but I could go through this quickly. So the beta-lactam ring is shared between cephalosporins and penicillins, and cephalosporins have an R1 and an R2 chain, and penicillins have a single R chain, which is analogous to the R1 chain of cephalosporins. I was taught in medical school that there's a 10% cross-reactivity between penicillins and cephalosporins. However, as we're learning more about this, we understand that it's less than 2%. However, the caveat is we need to understand that very common medications prescribed in our practice are aminopenicillins and aminocephalosporins, so we need to be mindful of the R1 groups and the R2 groups. So this is a paper, this is a review article we put out, and this is documenting the different R chains and R1s and R2s that are shared between penicillins and cephalosporins. One thing to note is clinically relevant, well, they're all clinically relevant, but due to the frequency of prescription practices, the aminocephalosporins and the aminopenicillins of cefadroxil, cefprozil, ceflexin, and cefaclor are analogous to amoxicillin and similar to ampicillin, so we need to be mindful of that. Of note, we have a couple of patients in our clinic who have ceftazidime and aztreonam cross-reactivity patterns, and we have a couple of patients also in our clinic that share the R1 among the third and fourth generation cephalosporins. One thing to note is that our patient was on Ancef, and Ancef actually has no side chains that are similar between any other penicillins and cephalosporins. In our small cohort, cefazolin is the implicated drug in intraoperative anaphylaxis, and it appears to be due to the R chain so far. It's the most common cause of intraoperative anaphylaxis in the US, but I'm not saying that it's the only cause of intraoperative anaphylaxis. So here was our testing strategy. We started at epicutaneous testing for the medications we found to be more high risk: rocuronium, vecuronium, cisatracurium, propofol at 2 different concentrations, ondansetron and granisetron, cefazolin and ceftriaxone, and this is ciprofloxacin, levofloxacin, and moxifloxacin at 2 different concentrations. The patient was negative. So we went on to extended intradermal testing to some of the other medications. So these are all of these fluoroquinolones on the side. This is penicillin G at 2 different concentrations, propofol. And here are the beta-lactams. So pre-pen, minor determinant, ampicillin, and as you note here, cefazolin was markedly positive. Interestingly, ceftriaxone was not positive, suggesting that it is not a cephalosporin backbone problem, but it's more of an R chain problem due to cefazolin. The canes were tested as well and were negative, as they often are. And so what we provided for this patient was an amoxicillin oral challenge, followed by a Keflex challenge, followed by a lidocaine sub-Q provocation, and the patient did very well. Because our pre-test probability was such that we were expecting likely cefazolin to be positive, and it was, we implicated cefazolin in the patient's intraoperative anaphylaxis, and we had stated it was safe to administer all of their penicillins and cephalosporins. And we also said the patient was safe to administer lidocaine. And the patient's actually due for surgery today. So I can't provide you much feedback, but we have had patients similar to this who we've sent to the operating room, and they've done very well. And so lastly, I would like to discuss a transplant candidate with a Bactrim allergy. So this is a 36-year-old female with ILD due to surfactant disorder with associated chronic respiratory failure. At the time was undergoing transplant evaluation, presenting for evaluation of Bactrim allergy. And she has no other medication allergies. And PJP is standard, prophylaxis is standard for patients status post-lung transplant, and Bactrim is still the treatment of choice for prophylaxis with a grade 1A recommendation. And antibiotic allergies are an automatic allergy referral for lung transplant and stem cell transplant evaluation at our center, and we often get patients on the liver transplant as well. And so her Bactrim reaction was that she took it when she was, so she's 36, she took it when she was 5 or 6, and about 8 days into the treatment developed a rash without any other symptoms that lasted a couple of days and went away without any sort of, she didn't even seek medical care, she just stopped it. And so our interpretation is that this is a low-risk Bactrim history. So approach to the patient with a sulfa allergy, the first step is understanding that there's no meaningful cross-reactivity between sulfa antimicrobials, celecoxib, and diuretics. In step 2, the initial questions should consider what type of drug it was and evaluate the risk of symptoms. And so we have to be very reverent when we're potentially evaluating for a Bactrim allergy, because it really can do it all. IgE-mediated, quote, quote, garden variety xanthan, SJSTEN, DRESS, a fixed drug eruption, AGEP. It can cause drug-induced interstitial nephritis and hepatitis. So when you're deciding whether you want to challenge a patient for Bactrim, you have to be really reverent of and really discern whether you believe that a serious, and I'll go through our strategy in a minute, there's a serious contraindication to giving the patient Bactrim again. And so we're unable to find a concentration of Bactrim testing that was non-irritating, so we go straight to oral challenge, and our target dose is 1 single strength tablet equivalent of Bactrim. And so just like the other figure, I have a traffic light for you as well. So for patients with non-severe reactions without IgE-mediated fashion, gastrointestinal symptoms, greater than 5 years ago, accelerated reactions, or an unknown history, we provide them with a single strength dose of Bactrim followed by 2 hours of observation. In patients who have had anaphylaxis or within 5 years, we provide a graded challenge of a 10%, 100% graded challenge to a single strength dose, 1 hour followed by 2 hours. And those who have severe T-cell mediated reactions are a contraindication. So this was recently published in JACI in Practice. So we took 195 HIV negative patients, of which the majority were in the single strength category, and 95% passed, and 86.3% passed in the two strength, of which 23% and 52% respectively of patients were re-challenged. And there were some patients who did have a delayed reaction, but the majority of whom tolerated Bactrim without any sort of problems. The majority of the delayed were delayed maculopapular xanthans, which resolved with either steroids or no intervention. There were no serious adverse events in that case. And so this patient was in the green light, so tolerated a single strength dose of Bactrim, and we had recommended that it was safe for her to administer sulfa antimicrobials. And she received a double lung transplant, and she took Bactrim very well after that for PJP prophylaxis. So my teaching points as I wrap up here is that drug allergy has a role for providing optimal care for patients. And beta-lactam allergy testing should be considered with all patients with low risk and many patients with distant immediate symptoms. Intraoperative anaphylaxis in our cohort was most frequently due to cefazolin. In fact, it was 100% due to cefazolin. Many medications used intraoperatively have non-IgE-mediated mast cell activating properties via touching MRGPRX2. A Bactrim reaction history should be carefully elicited due to its ability to cause multitude of dangerous hypersensitivity reactions. In patients with low-risk histories, Bactrim can be administered via challenge and effectively delabel a sulfa allergy when the initial sulfa in question was an antimicrobial. And with that, I would like to thank you all for providing me the opportunity to talk with you and answer questions and be here today. I appreciate everyone's collegiality. I'd like to very much thank my program director, Dr. Stokes-Peoples, and of course, my drug allergy mentors. I've learned so much from Elizabeth Phillips, and I thank her for her time and her mentorship to me, and also Cosby Stone. And with that, I'd be very happy to answer questions, but I was asked to remind you the word of the day was penicillin. So.
So I don't have a question, but I'll just say I think this is really great because drug allergy, I mean, as per our questions, I think a lot of people get caught up on some of the nuances, minor determinant this or that. None of that really matters in the end because drug allergy is really, personalized medicine. There's a right or a wrong. The patient's either allergic or not. And as long as you approach it in a reasonable way and you do it in a highly standardized and consistent fashion and collect data as to what is the outcome of the patient, which it sounds like you guys are doing, to a T, that's what matters because then you can actually affect the patient outcome, and have an answer at the end of the day. But I think the way you guys are doing this and the way you conveyed it is really perfect. And this is how drug allergy should be practiced. There can be, nuanced differences center to center, but as long as you're doing it in this sort of organized fashion, affect patient outcome in a positive way.
Well, in light of that, I'm wondering, when you were doing the intraoperative skin testing.
Yes, sir.
You're testing to a lot of drugs for which we don't have much, if any, published precedent as to how to interpret. So how do you interpret them, or are you collecting data to know if you see positives to drugs that we rarely test to, what's the mechanism?
Yes,
How do you interpret the collecting of that data?
That's a really good question. And I would say that many of these medications that we provided, we provide 2 different concentrations in order to potentially gather whether it's a non-IgE-mediated mast cell activation process, as is typical for many of the drugs in intraoperative anaphylaxis, or not. I would gather that Dr. Phillips is, a lot of the things she does is sort of uncharted territory. I do concede. But for example, one of the reasons why I feel comfortable with this result is that, I see probably 6 patients a clinic every Wednesday that are tested with cefazolin and ceftriaxone. And so our N for testing these with negative reactions is high enough for many of these that I feel comfortable. I feel comfortable with our testing schema. Does that answer your question? Probably not.
Well, I mean, but the question is, so if you saw a positive reaction to propofol or a local anesthetic, how do you know that it's IgE-mediated versus a pharmacologic reaction without in vitro proof that we know that there's an IgE antibody directed to some determinant on a drug which has never been well studied like penicillins have?
I think that's a good question. And I think that, we until we're able to capture IgEs to drugs, which I think hasn't really been done yet in a very great way, it'll be really difficult to answer that question. Scott Smith is an MD PhD at Vanderbilt who's the first to make hybridomas of IgE, and so he actually has different. We're hoping that this very patient right here is the first where we can capture IgE to cefazolin, but I think that's going to be a tough, yeah.
One thing to think about, I know it's probably not relevant for this specific patient, but it's chlorhexidine. I have some reactions to that, but nobody cut this guy open, so.
That's true. Yeah, we didn't quite make it to chlorhexidine, but yeah, that is very true.
Like a handful of times where it's been chlorhexidine that was the culprit.
And sometimes when folks have it sort of an industrial history of working around latex, we do add latex to our testing schema, but it's not our standard.
With regard to this sulfa-trimethoprim, I was at Fred Hutch for 5 years, and we had a lot of folks would come in with a history of sulfa allergy. And because of the pneumocystis prophylaxis program, we would do what we call the desensitization gradual, and they've done that in the HIV population too. Is there a mechanism, or is that just a slow challenge, do you think, that overcomes sulfa allergy?
So I think the first thing to know about Bactrim is that HIV patients and non-HIV patients are very different in terms of Bactrim. And there's a lot of, especially folks with AIDS, there's been data showing that drug pathogen interactions are really important for these. And so I didn't show you the HIV positive data in that paper, but in those patients, I think you should afford more caution based on their likelihood of more likelihood to react to Bactrim. And so we do slow desensitizations in our clinic for patients who are HIV positive who need Bactrim.
I've always had that question too, but I found out from SCC a very interesting thing that